Hi, Jafar.
Hi, sir. Good evening.
Good evening. Good evening. Good afternoon. Good evening.
So now we
Good
are
afternoon, sir.
Rahul. Good afternoon.
Please, Rahul.
Rahul must be joining back.
Rahul was there. Yeah, I think. Yeah.
Yeah.
He might have...
Good afternoon. Good afternoon, Rahul.
Good afternoon, sir. Yes, sir. All well.
We can
All
start.
good. All good. All good.
Yeah, so we can start, and we're live on YouTube also. To avoid any kind of audio issues, I'm muting all the speakers. Once you're talking, you can unmute from your end. Okay, so a very good afternoon and a warm welcome to one and all present here. I am Devulina from Claret. Let me take this opportunity to introduce Claret with all of you. As you all know, Claret is India's largest live digital CME and doctors-generated medical content platform, which is exclusively free for all the medical practitioners. So now with all of you, I'm going to share a short glimpse of Claret. Thank you so much, all the doctors, for your patience. You all are invited to visit our website, which is www.clanet.com. So now, without further delay, I would like to hand over the session to Dr. Prashant Karia to start with the scientific program. Over to you, sir.
So, good afternoon, everyone. On behalf of NNF Gujarat, I, Dr. Prashant Karia, Secretary Gujarat NNF, welcome one and all to today's neonatal Pathshala. I request President Sandeep Trivedi to welcome our guests.
Thank you, Prashant. I welcome Dr. Rahul Kadam sir and Dr. Jafar Khan sir and also coordinator Dr. Biraj Ben. And this is Neonatal Pathshala is the very good program which is useful to the neonatologist and as well as routine pediatric practice and also PG student also. And this is the brain of Dr. Somseskar sir, Dr. Ashish Mehta sir, Yogesh Parikh and Mohit sir. Thank you, Prashant, and I welcome to all. Thank you, Prashant. Hand over to you.
So, today's neonatal Pathshala is on different topics. We had a PG case presentation, PG seminars, a quiz, panel discussions, but this time we are having a Neo-Grandrounds, and it will be coordinated by Dr. Biraj Chakkar. Biraj is in charge of Akanksha and ICU, and she is in Anand. She has done her fellowship from Nirmal Children Hospital, and she will be coordinating today's grand round. So I welcome Biraj, and I request Biraj to introduce today's experts. Thank you.
Thank you, Prashant, for an introduction. And I would like to thank NNF Gujarat as well as the team Pathshala for providing us and allowing me to conduct the sessions on the Neo-Grandrounds. When we are managing a baby, we always stick to our basics first. But when we stuck at some point after doing the basics, we have to think beyond basics. And today we'll be discussing the same things, how the neo-hemodynamics help us in management of the cases where we stuck to some point. And for this discussions, we have our eminent faculty, Dr. Rahul Kadam. Dr. Rahul has done his DNB pediatrics, and after that he has done his fellowship in neonatology. He's currently working as a chief neonatologist at Ashwini Hospital, Bijapur. The special area of interest is point of care ultrasound. He's been faculty to various national and international, national and state level conferences. He had many publications in Index Journal, and he has been an author of various chapters in the neonatal book as well. Welcome, Rahul. And we have another faculty with us, that is Dr. Jafar Khan. He has done his MD pediatrics. After that, he has done his DNB neonatology from the Fernandez Hospital, Hyderabad. He's currently working as a consultant neonatologist at Lotus Healthcare Hospital, Indore. He's also an assistant professor at R.D. Kadri Medical College, Ujjain. His special area of interest is neonatal ventilation and neonatal functional echocardiography. He's the one who has just invested in the machine, and then after that he has learned the echo by himself. So his achievement is he has achieved a gold medal in the DNB Neonatology, and he has various publications too. Welcome, Dr. Jaffer. And I would even like to welcome all the audience and would like to request them to attend the call. It is very difficult to have interactions in the virtual sessions, but just to make the sessions interactive, we have generated polls. There will be 2 to 3 questions in each presentations. So I humbly request all the delegates, all the attendants, all the audience to attend the call by default, and try to make this more successful session. After that, I just would like to hand over to Dr. Rahul for his first presentation. Dr. Rahul.
So, very good evening, one and all. And at the outset, let me thank NNF Gujarat team for inviting me to this platform of Neonatal Pathshala. And our today's So to our today's session is on neonatal hemodynamics. So basically, we are going to take you through the cases. Here, we are not going to teach you that how we are going to perform echo and what we are going to see in the echocardiogram. In fact, we'll be just taking you through the cases, and what we want to do is we want to sensitize you people that how a timely functional echo can help you or help us to sail through a difficult situations when we stuck with some baby. So as Biraj said, I would have preferred it to be an interactive session, but when we are online, we may not be able to do it. So I'll be just taking you through a case of one baby which we came across last year. I'll share my screen. I'm not sure what is happening. I'm not able to see my video, but that's fine. I hope I'm audible. Am I audible?
Yeah, Rahul, you're audible as well as your screen is being visualized properly. The presentation is going well.
Yeah, fine. So let us begin. So yeah. I think I'll just turn off my video. Okay. Stuck. Give me a minute. I'll just not able to change. Okay, what I'll do, I'll just keep it like this because in slideshow, slides are not going forward. Even here, they are not going forward.
Rahul, even that happened to me, but right and left hand corner, there will be 2 arrows, right? If you select that arrow, I think you will be, just make it a complete presentation. Yeah, the slideshow, just make it slideshow. You'll be able to see right lower corner, the going ahead and backward. So that I think you can, that arrow. Yeah, is that okay? Yeah.
Thank you, Biraj, for making my life easy.
Pleasure.
Yeah, so let us start. So it was a term baby, male baby, birth weight was 3 kgs, born by vaginal delivery, and the antenatal period was uneventful. Baby was said to be cried immediately after birth. However, baby developed respiratory distress soon after birth and was started with a supplemental oxygen. As baby's respiratory RD was worsening, baby was referred to us at 4 hours of life. So when we received baby was having severe respiratory distress. Downey score was 7. Saturations in room air were 60%. Baby was tachycardic. Baby's CRT was delayed, and baby was hypotensive. So basically, what we are dealing with. So we have a term baby who has a severe respiratory distress. So it can be a term RDS, it can be a congenital pneumonia, it can be pulmonary hypertension, or it can be a underlying CHD, or it can be an underlying diaphragmatic hernia. We don't know. And what else we have? We have a shock, which can be either a hypovolemic shock can be a cardiogenic shock, can be a septic shock, or can be a multifactorial shock. So this is what the scene was. So what we are going to do next with this baby? So we have a baby with a severe respiratory distress and a shock. So what we are going to do? Obviously, we are going to stabilize the baby first. So we had to intubate this baby and we ventilated this baby on a SIMV mode with a moderate settings, and we started with a FIO of 50% to start with. We gave one 10 ml per kg normal saline bolus, and dopamine was started at 10 mics, and the first line antibiotics were started after drawing the blood cultures. So this is the X-ray. Actually, it is a zoomed view, so it's not pretty clear. So there was a bit of low volume lung, and there were retrocardiac air bronchograms, and there was a bit of haziness, though it was not total whiteout. There was a bit of haziness bilaterally. So what we did is we thought that it is a possibility of a term RDS, and then we gave a first dose of surfactant. However, this baby's ventilatory requirements went on increasing. We had to increase the pressures, and we increased FiO2 to 60%. And in 1 hour since admission, baby was olivuric, baby was tachycardic, and then still there was a shock. So we gave one more 10 ml per kg fluid bolus. So after this, what we will do? So obviously we thought of term RDS, shock is there, shock is still there, baby's requirements are worsening. So we need to think of something else. So at this point, we did a functional echo, and I think video you could see. Yeah. So what is wrong? Anyways, so I'm not able to play it. There's something wrong with it. Yeah. So as you can see, there was a significant TR and by eyeballing, we can make out that ventricles were contracting nicely. And as we can see, the gradient was around 47. So pulmonary pressures were around 50 to 55. So based on echo, we came to know that this baby has a moderate pulmonary hypertension. So what we did at this point is we stopped dopamine, and we started dobutamine. Though the cardiac function was normal, we started dobutamine. We anticipated that this baby may worsen, so we started dobutamine, and we started with the oral sildenafil. So however, this baby continued to have a continuous desaturations. We had to increase the support further. The mean airway pressure requirement went up to 12. FiO2s we increased up to 100%. Baby was still olivuric, still hypotensive. As you can see here, the blood gas at admission, it was a venous gas. There was a mild respiratory acidosis. By this time, we secured the lines, and the blood gas at 8 hours of life, you can see there was a significant respiratory acidosis along with metabolic acidemia, and there was a hypoxemia. PO2 was 49, and the OI oxygenation index at this time was around 24. So what actually we are dealing with clinically? So we had a hypoxemic respiratory failure, baby was in shock, and there was a metabolic acidemia. So I mean, this is a poll, I don't know how to do it. So basically now we know that we have a baby with a hypoxemic respiratory failure, is in shock, is having metabolic acidemia, moderate pH is there. Already baby is on a higher ventilatory settings with dobutamine is going on. So what you would like to do next? I mean, how to participate in poll, I'm not sure. So this is a poll. So okay. So you have options. So what you are going to do for this baby next? So whether you are going to continue on a conventional ventilation, you want to give one more fluid bolus. We have already given 2 boluses, and you want to increase dobit to 15 mics, or else you want to switch to high frequency ventilator and try one more fluid bolus and see how the things are. Or else whether you want to, along with high frequency ventilator, you straight away want to start nitric oxide, or else whether you want to switch to this baby on a high frequency ventilator, want to give a bicarb correction, and you want to reassess your heart function. So what you would choose?
Yeah, so all will have a 40 seconds time for the poll. Please attend the poll. Yeah. So we have a results. The 75% show that one should start with the HFOV and inhaled nitric oxide. 13% believe to start with the HFOV with one more bolus. We had already given 2 boluses. And there are 13% who believe to start with the high frequency with the alkali and repeat echocardiography. So please enlighten us, Dr. Rahul, how should we go further?
Okay, so actually, I mean, at last moment, I modified the option because I thought there will be a confusion between third and fourth. So those who have decided to go with third, that is also fine, because I mean, there's a moderate pH. We expect that this baby is going to worsen. I have changed the option here, but obviously, like what we know that baby's map on a conventional is almost 12 and effort is 100%, and babies having severe metabolic acidemia along with shock. So what we did at this point, I'm not able to go ahead. Sorry, again I need to go to that corner. So that corner is also not visible. Yeah, fine. So what we did is we put this baby on high frequency ventilator. We started with a map of around 12 and FI to 100%, and we gave one half bicarb correction because obviously there is a severe metabolic acidemia. Your pH is less than 7.1. Bicarb base deficit is almost 18. So obviously we need to correct acidosis for our other things to work. So that's what we did. We put this baby on high frequency ventilator and we gave one bicarb correction, and we repeated the echo. I think you can see it. So what we can see on eyeballing now that RARV is grossly dilated, and you can see as compared to previous video, the heart, even by eyeballing, we can make out that heart is not functioning, pumping that well. So, and now you can see like along with the TR, you have a MR also. Earlier there was no MR here. Now you can see that there is a MR as well. And then we measured the TR gradient, and now you can see the pulmonary pressures are whooping. They're more than 90. And then it's just a parasternal short axis view. We are seeing RVOT, and you can see there's a pulmonary regurgitation, and we just put a Doppler in a main pulmonary artery. And what you can see here is the blood flow in the pulmonary artery is reaching to the maximum very rapidly. That is what we call it as a pulmonary artery acceleration time that is reduced. You can see there's a notch in the middle of systole, mid-systolic notch, and we calculate one ratio. That ratio is less. So we measure the right ventricular ejection time. This is the right ventricular ejection time. And we see the ratio of pulmonary artery acceleration time and RVET. It was less than 0.2. And you can see here by eyeballing, we can see that LV is like a crescent. It is like a banana. And we have a bidirectional PFO. There is a bidirectional PDA, a large bidirectional PDA, and we have put a Doppler across the PDA. And what you can see that this is a hypertensive pattern. We see there are 5 patterns in the PDA. So this is a hypertensive pattern or PPHM pattern. Yeah, so what you can see, this is a subcostal view. What we can see that IVC is distended, liver is congested. So we just done a M mode across IVC. IVC is almost 9 mm, it is full. And this is a plaques, and you can see that fractional shortening is reduced. So LV is not contracting well. And this is what we have done, M mode across a tricuspid annulus. It is to see whether RV is functioning well or not. So you can see it is almost a flat line. So TAPS is very less. So there's RV systolic dysfunction. And if you can see here, this baby's right-sided coronary was dilated, and even LMCA was dilated. So we calculated Z score. It was fitting into the coronary dilation. There was no aneurysm. So by repeating a echo, what we got that earlier baby had a moderate pH. Now it has become a severe pulmonary hypertension. Baby has a large bidirectional PDA. There's a biventricular dysfunction, and coronaries are dilated. So now again, you have a pole. So till now, what we have done, we have put this baby on a high frequency ventilator. We have given a bicarb correction. We got a repeat echo done. Baby is already on dovitamin 10 mics. We got a repeat echo done, and we got that there is a severe biventricular dysfunction, severe PH, and coronaries are dilated. So what you want to do next? So what would you choose amongst? So again, 40 seconds.
Please attend the poll.
So whether you want to start sildenafil infusion along with dovitamin, whether you want to start nitric oxide along with dovitamin, whether you want to start nitric oxide and milrinone both, or whether you want to start milrinone and sildenafil infusion.
Okay, we have a result. And yeah, 67% are telling that inhale nitric oxide with milrinone. They just would like to start with the milrinone. The RV was quite failing. There are 8% who are in favor of starting with the inhale nitric oxide with the dobutamine. 8% are in favor for going for sildenafil and dobutamine, and 17% are for milrinone and sildenafil. So yeah, enlighten further, Dr. Rahul.
Yeah, so I think we all are on right track. So basically, we know that there was a severe pulmonary hypertension, and we want to get a PVR down. So, and you can see like oxygenation index is already hitting 24, and obviously the baby is fitting into the criteria where you'll start the nitric oxide. So we started with the inhaled nitric oxide at 20 ppm. We know that both RV and LV are not functioning well. So initially, and baby was hypotensive as well. So we started with epinephrine at a lower dose, and gradually over the time, we had to hike it up till 0.2 mics, and we kept it, maximum of 0.2 mics. And then we started milrinone with 0.5 mics, and later on we graded it up till 0.7 mics per kg per minute. So to get PVR down, we started with the nitric oxide, and for the biventricular dysfunction, we started with epinephrine and milrinone. So going further, despite starting epinephrine and milrinone, baby was still hypotensive, baby was still in shock, baby was oliguric, baby was hypotensive. You can see there was a bit of improvement in his systolic blood pressures, but diastolic pressures were still low. So we thought that, because of milrinone, the SVR is low, and that's why we started norepinephrine to increase the SVR. We started with a low dose, and then we ultimately had to hike it up till 0.2 mics. Despite that, the things were not well. So in between, once we reached the adrenaline of 0.1 mics, we added vasopressin as well at low dose. Again, we had to hike it up till 0.01 units. And after that, after starting norepinephrine and vasopressin, so we had to start baby on all these medicines. Now, the initial CRP of this baby was 9. Blood culture was sterile, and as the echo showed like worsening or a progressive disease along with worsening PPH, and there was a biventricular dysfunction and coronaries were dilated, we thought that it can be a neonatal MIS, severe MIS. So we repeated the we did the markers, and markers were highly elevated. The serology IgM was positive. So we thought of neonatal MIS, and then we gave this baby IVIG. We started with the pulse methylprednisolone, and we started with the low molecular weight heparin. So this is at one juncture during the treatment that baby was on HFO and nitric oxide and multiple infusions. And so what happened over next 24 to 48 hours? So once after starting the NOR and vasopressins, urine outputs, they started improving, blood pressures, they came into the normal range. Reductal sats were more than 90%, and even the POTs in blood gas started improving. So now you can see this was at 48 hours on HFO. Now you can see like heart is contracting in a better way than earlier. Yeah. And what we did is, again, we did a TAPSE, and you can see now the TAPSE is improved. The RV function started improving. Earlier it was a flat line. Now the RV function started improving. Similarly, earlier the LV was crescent sept. Now the septum started, I mean, it is becoming flat. I mean, it's still pH, but it is improving. And then the fractional fractional shortening of LV improved. And this is just modified plaques, and we are seeing a TR gradient. And the PA pressure started falling down. It is still high, but it is much better than earlier. Earlier, the gradient was almost around 85. Now it is around 51. So things started improving. But this baby had a stiff FiO2 requirement. With this support, we were not able to come down on the FiO2. Whenever we touch the FiO2s, baby used to desaturate, and blood gases, the PO2s will fall down. So as we confirm that the cardiac function has improved and the blood pressures are in normal range, still baby is requiring a stiff support, we started sildenafil infusion as an adjuvant to the INO. And ultimately, on day 4, we could come down on the FiO2 slowly, and the PO2s were in the acceptable range. So on day 4, we could start weaning the nitric oxide, and by 5th day, we could wean this baby off nitric oxide. This baby required a high frequency ventilation for 5 days, conventional ventilation for another 4 days. And this is the list of medicines what we had to give. Vasopressin we could taper after 24 hours and we could stop. Both norepinephrine, epinephrine we had to slowly taper, and we had to give them almost for 6 days. Milrinone we gave almost for 8 days. Sildenafil infusion for 3 days, and we even gave thiamine to this baby for 3 days. So we weaned this baby to HFNC on day 10 of life. Now on day 12, this baby again had an episode of desaturation. So that time baby was tachycardic, baby was tachypneic, there was increased work of breathing. On HFNC, we had to increase FiO2 till 60% at this time, but there was no shock and the sensorium was normal. So we were like, "Arey yaar, abhi kya ho raha hai?" Matlab, we were kind of no more. Matlab, what is happening? So again, this time functional echo came to our rescue. And what you can see, as the pulmonary pressures fell down, the shunt in the PDA, which was bidirectional, it became left to right. So there was a large left to right PDA. And earlier we saw there was a hypertensive pattern in the duct. Now you can see this is almost like a growing or pulsatile pattern in the duct. And then this is just, we are doing the Doppler in the main pulmonary artery. And what you can see, like this is a systole, this is a diastole. So usually diastole will be quite in the main pulmonary artery. Here you can see there's a lot of, there's a lot of diastolic turbulence. And then the plaques view, you can see clearly that LA is dilated. You can see here LA is dilated, and LA to aortic ratio is elevated. So what we had this time, that shunt has reversed and that this PDA has become left to right, and there's a pulmonary overcirculation. So at this juncture, we reduced the fluids judiciously. We restricted the fluids and we started this baby on diuretics. Over the next couple of days, baby started having improvement. We could taper and wean baby from HFNC on day 15 of life, and diuretics later on we tapered and stopped. And ultimately, on day 20 of life, we could discharge this baby home with the intact survival. Baby's neurosonogram was normal, retina was matured, hearing screen was normal. And this is a video of the baby at 8 months. Baby just came to our OPD for follow-up. So with this, I have few take-home messages. This is a familiar slide. Lot of many of us must have seen this. This is from Dr. Satyan. So this slide in a nutshell will tell us about the management of PPHN. The only point is, whenever a criteria is meeting, use high frequency ventilation and nitric oxide early rather than allowing this baby to deteriorate. Again, this is a familiar slide, and what we know that shock is not equal to hypotension, and any baby you assess it with a functional echo for volume, cardiac output, and myocardial function, and then you can have an individualized pathophysiology-based hemodynamic approach. What I mean by no routine fluids, I mean no routine preload augmentation for all babies. Your inotrope selection should be based on the hemodynamic derangement, and one size it does not fit to all baby. And in case of PPHN, so if you have a systemic hypotension but the cardiac function is normal, then your agent of choice should be either dopamine, norepinephrine, or vasopressin. But if you have a systemic hypotension along with cardiac dysfunction, as in our case, your agent of choice should be epinephrine and milrinone. We know like milrinone and can cause a fall in SVR, and to get the SVR up, once the cardiac function is a bit stable, then we can add vasopressin or norepinephrine. So with this, to conclude, sorry, again, one more familiar slide. I guess Mohit sir is there. So any baby who is unwell or collapses in your unit, use point of care ultrasound to get more inputs. Obviously, TABC is first stabilize the baby and then assess. And to conclude, I would say the illiterate of 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So keep calm and learn scan. Thank you.
Thank you, Dr. Rahul, for such a wonderful message at last. And thanks for a very nice presentation, which was a video-based presentation. And congratulations for saving this child who looked quite critical initially. And I think we don't have much time. We'll be able to take only 2 to 3 questions right now. All the delegates are requested to put the question answer in question answer sessions. And if time permits, then we can take more questions later for Dr. Rahul. So are there any questions in QA sessions or chat box for Dr. Rahul?
Dr. Biraj, Debalina can confirm if there are questions on the browser, because we have people here on Zoom, but many are there on the browser. And Dr. Rahul, very good presentation, very nicely, well done.
Thank you.
Are there any questions?
No, ma'am, we have not received any question on YouTube and no question from Zoom also.
There is one from Urvi.
Yeah, one question.
Why oral, not IV? So there is one question by Dr. Urvi. Why oral sildenafil and why not the IV sildenafil? So Dr. Rahul, would you like to enlighten on the same, that why did you select oral sildenafil earlier, or what is your experience about the oral sildenafil against the IV sildenafil?
Yeah, so I mean, initially we knew that baby had a moderate pulmonary hypertension, and that time still there was a shock, and we thought we'll first start a dobutamine, and once the function improves, then probably we'll change it to the IV. And for time being, we just started oral sildenafil. We knew probably it may not help also, I mean, this particular baby just deteriorated very rapidly. So initial oral sildenafil, we just started thinking that because baby was in shock and the IV sildenafil infusion may further worsen the things, and we were anticipating that baby's cardiac function may worsen. So that's why we started dobutamine, and just for some time we started with the oral sildenafil. Later on, when baby was on a nitric oxide and baby was not improving, that time we started IV sildenafil.
Okay, so oral, you were worried about the hypertension more with the IV, and that is why initially you just gave a trial for the oral sildenafil. So do you have experience that oral sildenafil causes less hypertension, or oral sildenafil can also lead to a similar hypertension?
Actually, not sure, because baby is already in shock. So we were not sure about the cause of shock, what is happening to the splanchnic circulation, oral sildenafil, how much it is going to get absorbed, and all that all was dubious.
Doubtful, yeah. Okay, I hope Dr. Urvi, it was clear. There is one more question by Dr. Manan Parikh. Any role of Maxilf in case of PPHN? We'll be able to take one more after this. Any role of Maxilf in PPHN?
I'm not really sure. I've not come across any literature. We have so far never used Maxilf in the PPHN.
Okay, and there is one more question, that how can we manage the patient in the case of unavailability of the inhaled nitric oxide?
Then that's tricky, probably. I mean, if your baby starts improving after starting the proper inotropes and lucitropes, and once the cardiac function improves and once the saturations are normal, probably we just have to hang on till the time things improve, and then once the cardiac function improves, probably we can try sildenafil infusion.
Yeah, it's basically the fine balance between the systemic tension, systemic pressures and the pulmonary pressures. So you just try all the measures to get down on your pulmonary pressures and try to increase your systemic pressure so that the shunting will be less and your oxygenation would improve in absence of INO. But INO is wonder drug. It is definitely, as you mentioned, very tricky to manage the babies in absence of INO. So I think no more questions right now. And if we have any, you can keep on asking in the chat box or QA sessions. Will be, if time permits, then we'll answer those in at the end. Now I would like to request Dr. Jafar Khan to start up with his presentation. Dr. Jafar, you need to share your presentation.
Yeah. Thank you, NNF Gujarat and Dr. Biraj, for giving me chance for presentation in Gujarat NNF in neonatal Pathshala. When Dr. Biraj request, what is happening?
You need to go for the full screen. I mean, the slideshow.
Okay. Yeah. Is it okay?
Yeah, that's fine.
Okay. So I have sent some couple of cases for case management after introduction of echo machine. How that echo machine have changed our management in neonatology practices. So the objective of this presentation, how echo machine helpful in difficult times. Like suppose that Dr. Rahul have given good presentation about the management of the PPHN based on the neonatal hemodynamics. But there are some other cases where we have the baby which is not responding to our routine measures. So in such difficult times, we have to know what is the exact cause of deterioration. And sometimes baby who is having sudden deterioration, but there is cause is not obvious, like they may it might be respiratory cause, it might be some electrolyte disturbance, it might be some cardiac causes, and we have to give answer to the parents as well, what is the cause of this sudden deterioration. And we have very limited time, or we have very less time to save the baby, because if we are not able to diagnose earlier, it could be detrimental for the baby. Whatever we do for the baby, that could be detrimental. So we have to target our treatment based on the that exact cause of the deterioration. And sometimes we have to locate the lines based on the USG. So I'm presenting two cases here. One, this is first case, acute deterioration, unexplained shock, and poor perfusion in stable preterm baby who was day 7. So this baby AY, I got a call early in the morning at around 8 o'clock. It's not in midnight, but early again in the morning, it was very scary call. The baby who is preterm IUGR, 32 weeker, 1.1 kilogram. The baby was obviously IUGR. The baby was not having RDS or something like that. This baby was having some routine care like nasal pump oxygen, that too is like 0.5 to 1 liter per minute. Baby was started with trophic feed and gradually increasing the feed, and baby was on total parental nutrition because we are not able to reach full feed by day 6 or day 7, so that TP1 is going on. So on day 7 at around early in the morning, one nurse called me. The baby is having excessive cry, some episodes of apnea, and with that some stimulation baby came. That and then she noticed that baby is having poor perfusion and dusky, and that baby started deterioration in last 30 minutes. Then I attended the call. So by that time I reached, baby was having deep apnea. So immediately we secured the respiratory system, because already if baby who is having dusky and not breathing, so first thing we have to do the secure the airway. So baby was intubated, connected to ventilator, SIMB 15/5 with FiO2 of 50% to be safer side started. And after ventilation connecting the tube, just we start the searching the cause of this sudden deterioration. So the transformation done, because this is the one we can early pick up some causes, like some dope test, like if some babies may have that spontaneous pneumothorax. So the translation is a test when we can very routinely and easily do, and it is doable by anyone. So we did that. It was negative. There was no pneumothorax. BP was not recordable. So we have started with a bolus of normal saline 10 ml per kg. Baby's heart rate was very high, 200 per minute, but initially it was 130 or 140, something like that. Baby was having poor plethysmograph. Pulse was not palpable. So we started with dopa and dopamine. And on auscultation after ventilating, air entry was fairly equal, and there was equal chest rise in both the sides. So whatever we did, like ventilation, inotrophs, and IV fluids and bolus, there was no change in the color. There is no change in the perfusion. Heart rate was same. In fact, it was increasing. Pulse volume was same after ventilation and inotrophs and fluids. So we are in a dilemma that we have done. Suppose if baby is having only just apnea, so by ventilation, baby must have been improved. If baby is because of some poor perfusion or poor hypovolemic, then after bolus it should start improving. But after doing all these things, there was no change in the baby's condition. So what test available, because baby was already for last 6 days with us, so we have some investigation beforehand, like sub CBC, CRP, blood culture were already we have sent on day 2, day 3. They are normal, like CBC was normal, and culture what we got just day before yesterday, it was sterile. So again, whenever baby deteriorated, we again have to go for some other tests or some new tests. CBC, CRP was repeated. Blood culture again we sent. We don't know what we are dealing with. ABG was done. X-ray chest being ordered, and electrolytes and calcium being done. So after investigation being ordered, that blood gas came. The pH was 7.2, PaCO2 of 28, base deficit was minus 18, bicarb of 6, PO2 of 88, lactate was very high, 20 millimole per liter, sodium was 142 in blood gas, potassium was 4.5, and calcium was 1.2. So looking at this blood gas, it is having some metabolic acidosis along with some partial compensation with respiratory alkalosis. So ABG was showing metabolic acidosis with partial compensation. So up to this, we are sure that the cause is not respiratory. It could be something else, whether it is sepsis or some cardiac issues or some metabolic abnormality, something like that. Because day 7 is the uh, age when some cardiac drug dependent disease also come across in the newborn baby. So we have to worry about that also. So X-ray, it was just day before yesterday we did the X-ray. It was showing like this. So looking at the X-ray, the lungs fields were very nice day before yesterday only. So here the opinion poll. So what could be the cause of this sudden deterioration? Hello.
Yeah.
Yeah.
So what could be the cause for this sudden deterioration in Jafar Khan's case? That is it the sepsis? Is it the IVH which can cause? Is it the congenital heart disease? As he mentioned, some drug-dependent lesions might be presenting at that time. Or it can be the pneumothorax. So we do have an X-ray in our hand before that. Or it can be anything, all of above. So please answer the poll. We will be having 40 seconds for the same. Can it be sepsis, IVH? Can it be anything, all of above? We do have Paul in our hand, and 56% just tells that it can be anything. It can be all of above. No pneumothorax because definitely we had an X-ray before that. And it can 11% are still thinking about congenital heart disease. There are 11% who thinks about who are thinking about the IVH, and 22% are in favor of sepsis. So we are closing it now, and then you can enlighten that what actually it was.
Okay. So it could be anything like sepsis. So if we talk about the sepsis, so initial day before previous 2 or 3 days before we have CBC CRP, which was normal, blood culture was also normal. So sepsis is less likely, and sometimes if we have the sepsis, there is a not sudden deterioration. In sepsis, what we have some apnea, then some desaturation, and then perfusion blood. So it could be sepsis, but in so many cases, sepsis the deterioration is not that sudden. So the possibility of sepsis is there, but it is not 100% we are sure it is sepsis. Pneumothorax, already we have seen that transformation test was negative, air entry was equal, chest size was equal, and if we look at the blood gas, PSU was okay. So that pneumothorax is ruled out. Then next cause could be electrolyte imbalance, some hypokalemia, hyperkalemia, hypokalemia, but in ABG it was normal. So next comes to the cardiac disease, because possibly day 7 and sudden deterioration, metabolic acidosis with high lactate. So possibly it could be a cardiac disease or some duct dependent circulation or something else. IVH, it could be the reason for that IVH, but we need to screen with USG machine, and there could be some effusion because already line was there, so it could be pericardial effusion or it could be that pleural effusion. So uh, before coming to any conclusion, we have to do some other tests as well. So we need more help from the other tests so that we come to the conclusion what is the cause of this. So we are clueless at this point. Baby was sinking because there was no improvement with whatever we have given. Parents were continued to be counseled with the regarding the baby's disease. And me and one of my friend whose baby was admitted with me, he also came by that time, and he was also confused what to do because already ventilation, fluids, boluses, inotrop, everything was given. But luckily at that time one more friend came, and he just came to meet me, but I called him as well. He was also he a neonatologist with fellowship from Pune. Then he came to NICU and he suggested, "Okay, why don't you see for the IVH?" At that time we don't have the machine, so we called the machine from radiology department. It was not NICU's machine, but anyway we called the machine. So NSG was done. There was no IVH. Again we are clueless because IVS was not there. And at that time, we three pediatricians were there, and all three were trained in fellowship and DNB neonatology. But we are not formally trained in the echo at that time. But anyhow, I told them he will do the echo, and just I put the probe on the chest. So what I found is that so it was a big massive pericardial effusion was there. And when we see that there was a history of pick line just day before prior it was there. So it was confirmed that there is a pericardial effusion, and that heart is not properly contracting. Because of that, nothing was working. So we called the cardiologist, and he told that he is in some procedure. He will not be available at next 2 hours. And at that time, we have only one pediatric cardiologist in Indore. Right now, we have four, but in 2016 we have only one. So here the baby was sinking, and then he told he is not able to come. So what we did, we decided, we called the parents and we saw the YouTube how to do the pericardiocentesis, and then we did the pericardiocentesis. And before that we have some images. We saved some images of the echo. So in this image you can see there is a rim of this one, that effusion around the heart was there. Some more images which was showing effusion around the heart. So when we, so at that time we are not properly trained, but at least we can see the fluids, how the fluid looks like, how the heart look like. So at least we have confirmed that it is the cause of this sudden deterioration is pericardial effusion. So we save the image, and we just for the parents sake, it is the cause. And then we aspirated around 10 to 15 ml of eye fluids with just extra color, and we sent this fluid for biochemical examination, which showing that sugar of around 400 plus. And after aspirating around 10 to 50 ml of pericardial fluid, baby improved dramatically. BP came, heart rate settled in next few minutes. Within a minute, heart rate came down to 140, 150, and in next 2 hours, we extubated the baby to again nasal pump oxygen. And this is the baby who is now around 5 or 6 year old. So this is how we able to manage this Misty with the help of echocardiography, because without that we are not able to pinpoint the diagnosis of why the baby was having sudden deterioration. I would like to share the second case, which is having the baby who is preterm and admitted for RDS but having pulmonary bleed on day 4. So this baby who is preterm IUGR, again 30 weeker, 1 kilogram female baby, which delivered by elective C-section due to Doppler compromise. On day, baby was having respiratory distress, hence baby was put on the CPAP. Baby was given surfactant with insure technique. Traffic feed was started on day 1 and TP1 started on day 1. Baby was very stable on day 2 and day 3, continued of 5 of PEEP and FR2 of 30%. So baby was doing well. Screening CBC, CRP being done, which was normal. So there was no antibiotic was given on day 1 because there was no risk factor for this. On day 4, what we noticed, one of the staff noticed that baby's heart rate was gradually increasing. Initially, we have the monitoring, it was 140 to 160, now it is increasing to 170, 190. Respiratory rate was also increasing from 50 to 60%, because on CPAP initially it was 30 to 40, but it was increasing to 50, 60. SpO2 was falling 85 to 91. So some registrar told that just increase the settings. So PEEP was increased. Anyone who will do with this setting, try to increase the FiO2 and all these things. So PEEP was increasing from 5 to 6, FiO2 increased from 30 to 60%, and flow was also increased. So with this subtle changes, which is showing just deterioration, like heart rate was increasing, respiratory rate was increasing, and SpO2 was started decreasing with whatever the previous setting were there. So settings were increased, and we are just trying to settle the baby with increasing the settings. So what would be the first action by duty doctors in this scenario? So this is the poll here. So whenever you see that the baby who is deteriorating on CPAP, so what should be our first action? So here is the poll.
Yeah. Would you like to do the X-ray? Would you like to call for the echocardiography? Would you like to do the transillumination test? Or would you like to do the intubation for this child? We'll be having 40 seconds. Yeah, so 78% are in favor of doing the transillumination and checking for the pneumothorax first. There are 11% who would like to order the X-ray, and there are 11% who would like to order for the echocardiography. So now what is the further according to you, Dr. Jaffer?
Yeah. So we know that where the baby is on any respiratory support, or whether on ventilator or on CPAP, so whenever we find that the baby is started deteriorating, so we have to have any test which can we do the bedside. Suppose if we order X-ray, it would be a very late, because it will take at least next uh, 20 to 30 minutes. Echo, there is no indication as such at this moment. And third is transformation, because already we know that baby is on CPAP with the surfactant being given. So here the question would be, the answer would be transformation, because this is the test which, if in expert hand, can be easily done in NICU only, and in a few fraction of seconds we can do this test. So here we have to go for the trans elimination, because the baby who is deteriorating, and if we find that there is a pneumothorax, so by the time X-ray or something or other tests come, we can put the we can find out the any tension pneumothorax, and we can drain the air. So with this transformation we can just save the time, and we can avoid the ventilation and other things as well. So if we see then we are just thinking why baby is having so what could be the reason for this worsening? So it could be a worsening RDS because already baby was day 4 and on CPAP not win from that. So it could be worsening RDS. It could be infection. It could be pneumonia. It could be PDA or it could be a pneumothorax. So there are n number of causes which can lead to deterioration or worsening of distress at day 4. So transmission was done, which was negative. CBC CRP was ordered to just rule out any sepsis. Blood gas was planned. X-ray was ordered, and one bolus was given because baby was having sudden tachycardia. So one bolus was started at 10 ml per kg. So in next 5 minutes, baby was sinking very fast. Soon baby was having fresh frothy pink secretion from the mouth, so that baby was having sudden desaturation and apneic episode. The baby was intubated because baby who is breathing from the mouth, so we have to think of the any pulmonary bleed. Baby was intubated, fresh blood coming out from the tracheal opening. ET was placed connected to the ventilation and ET suction was done continuously. So baby was investigated with CBC, CRP, blood gas, PTINR, APTT, X-ray being ordered. Investigation work came and that revealed that hemoglobin was dropping 12 gram percent, PET was 1.5 plate, PTINR was okay, that PT was 6, INR was 1.4, APTT was okay. Yeah, and X-ray came, which was this line. So after ventilation and intubation, X-ray was ordered and it was showed that diffuse haziness. But here the cardiac salute could not be appreciated because of the diffuse alveolar bleeds. So again, what could be the cause of this pulmonary bleed and all these things we cannot make out with only all these tests, because the few tests what we order except low hemoglobin, everything was normal. So what could be the cause of this pulmonary bleed? So whether it is coagulopathy, whether it is sepsis, or whether baby is IUG having bleeding, whether it is could be due to surfactant therapy or some other causes. So if we see one by one, coagulopathy, it's unlikely because PT APTT was marginally normal and there is no grass derangement in this. Sepsis, we know that sepsis comes with some warning signs like that: apnea, desaturation, color change, hypotension, renal shutdown, and then finally, when the babies uh, have MODS or DIC, then bleeding comes. So sepsis is also unlikely in this case. IUGR, it could be because of some prematurely treated or IUGR related. So it could be the cause. Surfactant therapy sometimes lead to the opening of the PDA and there is a volume overload. So it could be the cause. But again, surfactant we have given on day 1, but the bleeding was on day 4. So there is a remote possibility this could be the cause of bleeding. Next cause comes like renal failure and overload. These are the also causes of the pulmonary bleed. But here in this baby, there was no such warning signs like edema, oliguria, anuria. So looking at all these examples, we are not able to find out what could be the cause of this uh, pulmonary bleed. So whenever we find out that PT APTT being normal, X-rays diffuse that opacities. So before planning anything, what could be our first choice or first plan of action in this case? Opinion poll here.
Yeah. Shall we transfuse FFP on platelets, or shall we go for the inotropic support? Start with inotropic support, or one should upgrade the antibiotic, or one should order the echo. So kindly attend the call. Again, we'll be having 40 seconds. The coagulopathy is not there. The PTINR is normal, but what should be the criteria when baby is already bleeding, having a pulmonary bleeding? Shall we transfuse FFP and platelets, or shall we update antibiotic or increase the inotropic support? Yeah, we have a result. So there are 45% who are in favor for going for the echocardiography. Nobody is in favor of upgrading the antibiotic. I'm happy by seeing this. There are 27% who would like to start with some inotropic support, and there are 27% who would like to transfuse with the FFP and platelets, though the platelets being 1.5 and INR was being normal, but that was pulmonary bleed. So, Dr. Jafar, what was the final management?
So if we do the first step here, so I think majority have chosen the echo. So it is the right answer, because by the time whatever information we have, so anything if we do unnecessarily, it could harm the babies and it could further increase the pulmonary bleed as well. So being PT APTT being normal, baby is not looking septic, so we'll wait for the FFP and PRP and we'll try to pinpoint the cause before giving any transfusion, because already the baby started frothing and all this after giving the boluses. So we have to think of that, whether this bleeding is because of some overload or some chamber dilatation or something like that. So before confirming the pinpoint cause, we have to we should not give any unnecessary infusions to this baby. Same with inotropic support, we have to confirm the other causes like that cardiac contractility, volume and all these things, then we have to add. Same with antibiotics. Here, the clear-cut case, the baby is not looking septic at all. There was no respecters of sepsis, and we know that antibiotic is not magic bullet. It will not work immediately. Even if it is sepsis, it will have some time. So the echo is best option here, because with this echocardiography, we know we can have so many information like first thing we can know the information about the volume, whether the volume of the system, it is optimal or suboptimal or it is overloaded. And we know the information about the cardiac contractility, we know the about the PDA and PDA size, whether it is HSPDA or normal PDA. So first thing we have to do the, you just put a prop and it is a very we can do bedside and the information will get a very quickly, other than other investigation. So we'll go with echo. So before the management plan, we have to think update what to do, whether we have to give FFP, PRP, PRBC, inotropic support, upgrade the antibiotic or switch to HFO. So these are the option of management, but which we have to choose so that it is betterment for the baby and it's not going to harm the baby. So whenever we have we have doubt, we have to take the opinion from the third umpire always in the cricket. So here our third umpire is our echocardiography machine, whether the cause is, whether it is cardiac cause or something else. So at least cardiac cause, volume or under volume or overfilled, we can rule out from the echocardiography machine. So when we see that, so from eyeballing and at least from echo, we can see that there all the four chambers being dilated, atria is also dilated, right atrium, left atrium and chambers as well. So when we see the other causes, so when we see the duct, it was around 4.5 millimeter and LAO ratio of around 2.4. So whatever information we got from the echo, all four chamber being dilated, there was a decreased contractility, PDA of around 4.4 mm, mild TR was also there, and IVC was full, measuring 4.6 mm. When we saw the LAO ratio, it was 2.67. So definitely, what information we got from the echocardiography, the cause of the pulmonary bleed was volume overload. It is not because we have given fluid from the outside. It is the inside the, because baby who is IUGR having some cardiogenic myocarditis, and on top of that the duct was huge. So here the cause of that bleeding was pulmonary over circulation, And here the management totally difference, because if we go blindly, we'll transfuse the FFP, PRP, and inotropes. But here, once we get the information about the echocardiography, we know that now that chambers are enlarged, PDA is big one, IVC is dilated, it is, and that LAORS is more than 2.3. So here, what we saw that, then we started with dobutamine to increase the contractility. We started with Lasix to just give the increase urine, and we restricted the fluid that to. And after few hours, we noticed that bleeding started decreasing and the cardiac contractility improving. And then by day 2 or day 3, the duct was closed. And for this baby, we have not given any FFP or PRP. Just on same day, we have given some PRBC because hemoglobin was less. So by doing timely echo, at least we know the what exact treatment is required for the baby, so that unnecessary treatment which is going to harm the baby. Here, if we have given FFP and PRP blindly, definitely there will be a increased overload on the system, and there may be more bleed, or we can say that the bleeding would not have been stopped earlier, and we can lose the baby's life at this moment. So the take home message for this session: whenever we are in doubt or whenever we are not able to pinpoint our diagnosis, just call for the echo. And it is the simplest and fastest device available to clinch our diagnosis, because it is in the most of the unit, it is easily available and bedside. And nowadays, so many fellows and doctors are trained in the neonatal echocardiography. So whenever you are doubt, just go with echocardiography. uh, if you are in doubt how we'll learn the machine, so my message is that purchase and learn doing yourself as much as possible, and with the help of other mentors. You know that other mentors, those who are having now, such that Mohit Sani sir, Pradeep sir, and they are having good uh, YouTube channels to just teach them uh, all the functional echo and routine echo. Once you start doing your own, you would forget about the stethoscope and you will use for all the babies. So I I learn myself after purchasing the machine. Till date, I have done 20, I have diagnosed 20 plus more critical congenital heart disease, and that verified by cardiologists, and I have seen timely for the operation. So many critical cardiac disease like HLHS, RV hypoplasia have been diagnosed at admission, and some many parents refuse for admission and other things. So it is not very tough. You can learn your own by the help of some mentors. Thank you.
Congratulations, Dr. Jafar Khan, for saving both the kids. And thank you for such a wonderful presentation and the clear message of role of third umpire. The role of third umpire will be third only. They won't become a primary. Definitely, your basics is first. And after that, if required, then you can think about echocardiography and your third umpire role. Now, the session is open for question answers. We can take question answers. We are already running 5 to 6 minutes late. So, is there any question?
Dr. Biraj, there is a question. Dr. Manan has asked, is ET suction advisable in active pulmonary?
Okay, Dr. Jafar, is there an answer from, is ET suction advisable?
Whenever we intubate the baby and the baby is profusely bleeding, and if the baby is desaturating, so sometimes it gives the picture of like drowning. So whenever the baby is having bleed and all the alveoli and trachea is being filled with blood, so in that case we have to do suctioning, so that at least we can clear the airway, so it will give the good ventilation. If we don't do in such cases, definitely there will be a ventilation will not work, because all the small alveoli and ET will be filled with blood. So definitely in massive pulmonary bleed, it is advisable to do the pulmonary ET suction. And for that purpose, we have some closed suction device as well, where we have some catheter which is attached to the device, so that there is no need to disconnect the ventilator as well. By the side port, we can just do the ET suction without disconnecting the ventilator from the ET tube.
Yeah, if there's a massive bleeding, sometimes it is difficult to ventilate the baby. At that time, you may require to do the practically ET suctioning, but definitely should not be that much vigorous so that it would induces more and more bleed. So that is what the answer is. Is there any other question? Dr. Jaffer, by the time we'll get the question, I would like to ask you that we have observed that in your case, when the baby's IUGR, your PDA was treated by diuretics and fluid restriction. So is there any role of PCM or ibugesic in this case?
Yeah, definitely. There is a role of PCM and ibugesic, but it will have take time. So before that, we can just concentrate on restricting the fluid and as well as other inotropes, so that it will give the increased forward flow. So whatever volume overload we can decrease, and definitely we can add the paracetamol or ibugesic as well to shrink the PDA. That will definitely it will. But to help the paracetamol and ibugesic, we need the volume restriction as well. Otherwise, I think it will take time to.
Yeah, so
decrease.
it's basically, you mean treating the cause in case of a PDA, where in your case the PDA was because of volume overload. Even I think in the previous case of Dr. Rahul, he also managed the PDA with just restricting the fluid, because whenever you just found all the evidence on the echocardiography about the volume overload and the PDA being the cause for the same, just by restricting the volume and just by giving the Lasix furosemide, you may even treat the PDA. Sometimes PDA even could be the cause along with the sepsis, and just by treating the sepsis, you can get rid of the PDA. It is not always required to start with the PCM or ibugesic, as we do in case of the premature babies.
Sure.
Is there any other question? Or
Hi.
Yeah.
This is Mohit Sani. May I allowed to have two comments?
Yeah, sir,
Yeah, sir, definitely.
Now the role of third umpire.
Yeah.
Thanks, Dr. Jaffer, Dr. Rahul. Very nice presentation. Just couple of comments, a couple of things. In the previous, there was a question regarding magnesium sulfate and PPHN. So I think Dr. Manan asked that question. So yes, like magnesium sulfate does work. It decreases your pulmonary hypertension, but the issue with that is it causes a very resistant hypotension, systemic hypotension. So that was the reason it was being stopped. So that's why people have stopped using it, because we personally used to use it before sildenafil came into picture. So there was an issue with that, and there are quite a good number of studies people have done using magnesium sulfate with and without nitric oxide. So what they found is, if you start magnesium sulfate and then switch over to nitric oxide, the outcomes were bad. But if you are having nitric oxide, you started babies on nitric oxide and they are nitric oxide resistant, and you have used, and in those babies when they have started with magnesium sulfate, the outcomes were better as compared to the previous group. So there's nowadays people use it only in that group of babies of PPHN in which it is resistant to nitric oxide. They are non-responders to nitric oxide. So people have used that. But along with that, nowadays we start vasopressin or noradrenaline just to maintain the blood pressure. Yes, please.
Yeah, thank you, Dr. Sahani, for your enlightening us about the Maxilf, and that is a clear-cut role of Maxilf. Whenever there is a no response to INO, one may think about starting the Maxilf. Yeah, you were telling something so.
Yeah, so the other thing was IV sildenafil and oral sildenafil. So what the studies have already found is the onset of action between these two different routes is being different. IV acts immediately and oral takes at least 15 to 20 minutes to start with action, minimum 20 minutes. But the only issue is none of the studies have clearly done the bioavailability by pharmaceutical, by doing the levels of sildenafil with different routes. So bioavailability, we don't know that what is the bioavailability with the oral one. So that's why we are not certain if the babies are sick and hypoxic. Then we don't know that what will be the bioavailability of sildenafil through the oral route. So that's why in that cases, we prefer IV sildenafil. But
Yeah.
the end result is the same. It's only the onset of action, duration, and then the bioavailability of the drug that is different.
Yeah, because in case of shock, we expect blood circulation being on lower side, especially the gut perfusion. So at that time, we are not sure about the oral bioavailability of the sildenafil. I think there was a recent publication by Dr. Suryavanshi regarding oral and IV sildenafil. That was a pilot study, but that was mainly for the moderate and mild pulmonary hypertension, not for the severe one as it is in the case of Dr. Rahul's case. So thank you very much for the same. Are there any question or shall we sum up with the things? Dr. Rahul, I have a question for you if there are not any. What is the basically cutoff for the OI? Because we have seen many taking a OI. Is Dr. Rahul there?
Yeah, I'm there.
Yeah, because many takes a OI cutoff as a 15 and many takes 25 before starting the inhaled nitric oxide. So what is your experience and what is your practice to take a cutoff OI before starting inhaled nitric oxide?
So the cutoff given is a range actually. It's from 15 to 25. So based on the baby's sickness level, we can take a call. So cutoff range is from 15 to 25. So if baby is very sick, extremely sick, and if your OI is 16, 17, then also you are justified to start nitric oxide. So that's what I said. If you have a nitric oxide available, use it early if baby is fitting into the criteria rather than allowing baby to deteriorate.
Okay, thank you very much. So cutoff should be, if you have availability of INO, then your threshold for starting should be lesser, right? That is what your message is. Okay, is there any question? Okay, so shall we sum up the sessions with the summary? So today's summary, what we learned today is that TABC is the first thing. After that, when you just stuck up at something, at that time, we can have interventions with the echocardiography. If you have one or more than two boluses or more than one inotropic support, then always check the echocardiography before managing the shock. In a case of pulmonary hypertension, oral sildenafil versus IV sildenafil, IV has a acute or immediate onset of action against the oral sildenafil, and we are not sure about the viability of the oral sildenafil, so it's always better to have an IV. Your threshold for starting the inhaled nitric oxide should be lesser, and if you have it, you may even start with the OI more than 15. And there should be a fine balance between decreasing the pulmonary pressures and increasing the right-sided, that is the systemic pressures, to manage the pulmonary hypertension, especially when you don't have inhaled nitric oxide. And we had another thing is like PDA in case of full-term newborn or PDA in case of the IUGR would manifest differently. And one should treat the PDA, the cause of the PDA, rather than only jump on starting with the paracetamol and ibugesic. And dope is always first. And when you have a line in C2, you may think about the extravasation as one of the cause for sudden deterioration. Don't jump on changing the antibiotic in case of sudden deteriorations. Just think about the causes, what it could be. And in case of IUGR, always be cautious even while transfusing the boluses, because they do have a different hemodynamics. There are a couple of studies who had even shown that the cardiac output is more compared to the AGA baby. And that is why be cautious. And always remember the role of third umpire. It should be timely, not before, not after. I think that is what we learned today from today's sessions. Am I clear? Is there any other comment?
I think there's one more question just at the end. Dr. Manan has put one question, like, is there any prophylactic echo protocols in ELBWs to rule out IVH and PDA? So I'll just put it in a one sentence. It's not prophylactic. It is called as a targeted approach. And we have plenty of evidence available when to do neurosonogram. Even one of our chapters has, I can send it to Manan. And then functional echo also, usually for extreme preterm babies, less than 1,000 kilos babies, we do a, what you say is a targeted echocardiogram, not the prophylactic.
So there is a role of TN echo in case of ELBW, right? So not only at the time of deterioration.
I just wanted to share there are apps, online apps for iPhone and Android to learn targeted neonatal echos also. I think they are from Sick Kids Canada, and so those apps are available. So people can use online phone apps also.
So can
For
you mention
iPad,
the
iPhone.
name of the app, or can we put it in the chat box so that one can download it?
I will just share. It is you can look at TN Eco.
Targeted neonatal echo.
Sick Kids ka hai, Sick Kids ka app.
Okay, that's wonderful. So I think it's end of the session. So over to you, Prashant. Where is Prashant?
Maybe then Dr. Ronak, you want to close, or Dr. Sandeep wants to close?
Thank you, Dr. Biraj, and thank you, Dr. Jafar and Dr. Kadam. Nice session on the inotropes, and every time we are going to learn each and everything new and new, and basket is so big for me little. So thank you very much, and same link is using. Thank you, Clarinet, for given to opportunity NNF Gujarat with you, and thank you, Dr. Somsekhar sir and Ashish sir. This is your project, and due to this, all the pediatrician and neonatologists learn more and more in this session. Thank you very much. Thank you.
Thank you. Bye bye.
Thank you, sir. Thank you, sir.
Thank you.
Bye,
Thank
sir.
you. Bye bye.
Bye.
Thank you.
Thank you so much. We're closing here.
Yeah.
Thank you, sir. Bye.